Coronary artery disease is a disorder where the patient has decreased blood flow going to the heart. So this is a situation where we have maybe an atherosclerotic disease that's going on or whatever, and we're not getting enough blood flow to the heart. So coronary artery disease starts as being atherosclerotic disease, and then it starts working into causing additional problems with our patient, such as angina and myocardial infarction. So this diagram here is just showing you the process that occurs with endothelial injury and then the resultant changes that occur in the vessel. So you notice at the top we have a fairly normal looking vessel here. Maybe it's become damaged in some way, and microscopically over on the right hand side we're starting to get some response to injury. That starts to cause this fatty streak. The fatty streak is the result of having fat molecules that are kind of bunching together here with the underlying inflammation. So the underlying inflammation is causing the patient to have things like platelets and fibrin, etc., start to collect there. And the fatty streak, the fat molecules then start collecting on top of that. On top of the fat molecules, then we start to get this collagen or this fibrous cap. And the fibrous cap is now going to contain the whole thing so that it can't easily be removed from the body. Unfortunately, what also happens is the fibrous cap can tend to keep this thing well contained where it's not getting oxygen, and then we start to develop a necrotic core, and the necrotic core will then continue to maintain inflammation over a long period of time. Now this is a complicated lesion at the bottom where we also have a thrombus. So we've got not only this fibrous plaque that's inside the patient's body, but we also are inside the vessel, but we also now have platelets that are sticking to it, and we have a thrombus that has formed. And that thrombus can continue to get bigger and bigger and bigger and block the vessel, or it could break free, go downstream to a smaller vessel and block the smaller vessel. Risk factors for coronary artery disease, we break those up into two major categories. Our non-modifiable risk factors, not a whole lot you can do about your age or your gender, your ethnicity, your family history. Okay, so not a lot you can do about that stuff. So those are the non-modifiable risk factors, but we want to know about them. So we were going to ask our patient about anybody else in their family who's had any kind of cardiac disease. We're going to look at age, we're going to look at gender, and to get an idea as to whether or not this patient may be at high risk for developing coronary artery disease. There are several modifiable risk factors, though. Elevated serum lipids, we can take medications to help decrease the amount of cholesterol that's in the body, or, obviously diet would be the great thing to do first, is to modify the diet so we can decrease the amount of cholesterol in the system. But if not, then we can take medications for that that'll help to lower the cholesterol. Those are called statins, S-T-A-T-I-N, statin. Hypertension is a modifiable risk factor in that we can lower the patient's blood pressure with medications. Tobacco use, so we can have the patient stop smoking and using tobacco. Tobacco in general is going to have nicotine in it. Nicotine is a stimulant, and that stimulant is going to cause the patient to have an increase in heart rate, and it also irritates because of the carbon monoxide and other chemicals inside the cigarette smoke itself. It'll irritate the inside lining of the blood vessel too. Physical inactivity, obesity, diabetes. Metabolic syndrome is a combination of things that go into determining whether or not a patient is going to, it's kind of a triad of different modifiable risk factors that the patient can have that will lead to the patient developing coronary artery disease. Psychologic states can also, depression, for example, and homocysteine level. Homocysteine is one of those things that we can look at, we can assess, we can take levels of, etc., and find out what the patient's homocysteine level is. This is part of the inflammatory response, so we can modify it by modifying inflammation. Well, the worst end result of having a patient have atherosclerotic disease would be myocardial infarction. And in a myocardial infarction, we have a deprivation of our blood supply. Now let's take a look first at what's happening with a temporary loss of blood flow to an area of the heart. We get what's called reversible ischemia, and typically in most cases we call that stable angina. We can also have another condition that's called unstable angina, where there may be some injury that's occurring to the patient's myocardium, but it can be reversible in many cases. Atherosclerotic plaques can form in the coronary vasculature, and they can be stable plaques or unstable plaques. A stable plaque is simply just decreasing the amount of blood flow that's going through that vessel. An unstable plaque, on the other hand, this could be really dangerous because it could break free, it can go downstream, it can cause a clot and totally occlude a vessel, which could cause the patient to have a coronary syndrome. And by the way, we call these things now acute coronary syndromes. And the reason why we use that terminology is that terminology will then encompass everything from angina to myocardial infarction. So it encompasses more things than just breaking it down and saying, okay, the patient's here because they have angina, the patient's here because they have myocardial infarction. Instead, we're just going to say, hey, the patient's got acute coronary syndrome, which encompasses all of those things. Myocardial infarction, in this situation, the patient's got sustained ischemia for greater than 20 minutes. We call that a myocardial infarction because we're going to have damage to the myocardium. In fact, we're going to have necrotic damage to the myocardium. We're going to have some anaerobic metabolism occurring in the myocardium itself, which could help to maintain the metabolism, help to maintain that musculature for a period of time. Now, we can break down our MIs into two different kinds. We can call them a ST segment elevation MI or a non-ST segment elevation MI. What this refers to is it refers to whether or not we have changes occurring on our EKG. So we would take an electrocardiogram of the patient to try to determine whether or not they have a myocardial infarction. If, in fact, there were changes on that EKG, we would call it a STEMI, ST segment elevation MI. If there were no changes and we had to find out that the patient had an MI as a result of looking at our enzymes, our cardiac enzymes, we would call that a non-ST segment elevation MI. So let's break this down again here a little bit. Here's a little bit more information about the two of those. When we talk about a MI being a non-ST segment elevation MI, so non-STEMI, all right. Those are MIs that in general, because it's not causing EKG changes, in general, it's going to be a smaller MI than would be what we call a STEMI, ST segment elevation MI, so we're getting EKG changes. And we also refer to that as being transmural. Transmural means it's going all the way through the muscle. So subendocardial means it's not going all the way through the muscle, it's just going into the endocardium, and it's not going all the way through. So that's a little bit different. However, rather than talking about them in terms of transmural versus subendocardial, we refer to them by whether or not they have EKG changes. So in other words, we say it's a STEMI or it's a NSTEMI. Now, to get an idea as to what's going on with our patient here and how this all fits together, take a look at the diagram here. And the underlying variable that's happening in this diagram is atherosclerotic disease. So the underlying thing is atherosclerotic disease, and what we have is a continuum. And we're flowing down through the continuum based upon how long the amount of damage has occurred to the heart. So over on the left-hand side, we just get a little bit of a disruption of blood flow to the patient's heart, and we develop ischemia. That's reversible. That's called stable angina. So stable angina, we have ischemia to the myocardium, but it's totally reversible. It goes away as soon as the patient sits down, rests, or takes a nitroglycerin tablet, something that's going to allow those coronary vessels then to fill again like they normally should. Next, we move into an area where we start to get injury occurring to the myocardium. Now, this injury could recover if we're giving the myocardium enough time to be able to recover, etc. It could recover, so it's possible that that could recover. This is called unstable angina. In unstable angina, see, we're kind of in the middle here. It could go either way. We could go back kind of to the stable area and just have ischemia, or we could continue to progress into necrosis, which would be a really bad situation because now we're getting into that myocardial infarction. When we're getting a myocardial infarction, whether it's a non-ST segment elevation MI, okay, that's the one without EKG changes, or an ST segment elevation MI, that's the one with EKG changes, either way, we're getting necrosis of the myocardium. Now remember again, necrotic tissue is dead tissue. Okay, so it's not going to function. It's not going to contract. It's not going to carry electrical energy. So we have basically a dead area of the heart. And if that dead area of the heart is very large, then the cardiac output is going to be dramatically affected. Disorders of the heart wall, in addition to myocardial infarction, can include things like a pericarditis, so we can have problems with the pericardium itself, or we can have a pericardial effusion where we have fluid leaking into that space between the pericardium and the myocardium. We can also have disorders of the myocardium itself, like cardiomyopathies, and we can have disorders of the endocardium, that's the inside lining of the heart, which can lead to valvular disorders, such as stenosis or regurgitation. Let's take a look at some of those disorders. First of all, disorders of the pericardium. The pericardium, remember again, is the outermost layer of the heart, and the pericardium is keeping the heart in place. So it's holding the heart in place, but we can develop, in some cases, maybe from infection or trauma, etc., we can develop an inflammation of that layer. One of the main things that happens with this inflammation, first of all, it's going to be painful. But the next thing that happens with this inflammation of the pericardium is that it can develop fluid. You know, when you get inflammation in parts of the body, let's say that you sprain your ankle and your ankle swells. Okay, you're getting fluid in that area as a result of inflammation. Well, if we get fluid in the pericardium as a result of inflammation, that's going to start to build up fluid in there and squeeze the heart, and that's going to cause what's called a tamponade. This is a picture here showing a patient who had pericarditis. Now you look at the outside lining of the heart. That should be nice and smooth and glistening. Instead, it's all rough. So we obviously had a lot of inflammation on the outside lining of the heart, and that can cause some significant pain. And if it's infectious, that could really be a problem for our patient as the infection starts to cause dysfunction of the myocardium too. Pericardium, well, what can happen as a result of having maybe a pericardial effusion or a pericarditis is the patient can end up developing fluid in that pericardial cavity. We call that a pericardial effusion. Well, in many cases that may reabsorb on its own, or we may have to send the patient down to the OR and drain that fluid off. If the fluid creates too much, if it gets too much fluid in that pericardial sac, we can develop what's called a pericardial tamponade, in which case the fluid has starting to build up and is starting to compress the myocardium and compressing the ventricle, and so there's not enough room to be able to fill the ventricle. Constrictive pericarditis, this is a situation here where we're going to start to get some scarring and calcification, etc., in the pericardium and the pericardial sac, and that's going to decrease our cardiac output because the heart can't fully fill. It can't swell out enough and let enough blood fill into the myocardium. Cardiomyopathy is a term that's used to describe a change in the size and or the shape of the myocardial cells. Now this is a heart here in a patient who had what's called dilated cardiomyopathy. Dilated cardiomyopathy can happen in patients who have heart failure, for example, and the heart just in its attempt to try to pump better, what ends up happening is that the muscle starts changing its size and shape. And now you can see here, this doesn't look anything like a heart anymore. It's this big round thing. Instead of having that nice V-like shape that a heart should have, this is this big rounded thing. Now that's not going to contract very well. And we're not going to get a good cardiac output as a result of it. So the problem with cardiomyopathy is we get a change in the size and the shape of the heart, and that leads to decreased cardiac output. We can have other types of cardiomyopathies, including hypertrophic. This is the thing that we used to call a ventricular hypertrophy. So the muscle is starting to build up and get bigger, and that's impeding our ability of the heart to be able to contract. Restrictive, on the other hand, is a situation where we're also going to have problems with being able to have a normal cardiac output. Let's take a look at these pictures here. I think this might make it a little bit more obvious to you as to what's going on. Here's a normal heart at the top, so it's showing you the left atrium and the left ventricle, and you notice the shape of the left ventricle that we see there, a nice V-like shape. Go over to the right side, and you see we have dilated cardiomyopathy, that big round heart like we saw in the picture. Okay, now that's not going to pump very well. Remember, the ventricle is going to contract as a whole, like one big muscle, and try to pump the blood out. Well, it needs to have a V shape to do that. If it's got this rounded shape to do that, then there's going to be a lot of blood that sits in the ventricle that doesn't get pumped out. On the other hand, we can have letter C at the bottom there, a hypertrophic type of cardiomyopathy, where the patient has hypertrophy of the ventricular muscle, and now you can see the ventricle is so small we can't fill it adequately in order to maintain an adequate cardiac output. On the other hand, we can move over to D over here, where we have a restricted. And then restrictive cardiomyopathy, the ventricle does not contract very well because of fibrous type disease. The endocardium is the inner lining of the heart, and remember again that the valves attach to the inner lining of the heart. So one of the main problems we're going to have with disorders of the endocardium, such as endocarditis, is that it can damage our heart valves, and it can lead to either stenosis or regurgitation of our valves. So let's take a look at valvular dysfunction here for a moment. When we're talking about stenosis and regurgitation of the valves, what we're talking about is a dysfunction in the way that the valves are normally working. Stenosis means they're narrowing, so the valve is narrowing. Okay, well, let's say we've got 100 people that we need to try to get out of a room, and we have 2 doors, but only one of the doors works. Well, that's kind of like a narrowing of the valves. We're not going to get people out of that room as fast as if we had the 2 doors open. So that's the same kind of thing that's happening in the heart with the valves, is that if the valve is not opening fully, then we're going to have trouble moving fluid past it. So forward flow is going to start to decrease, and that increases the workload on the heart. That's from stenosis, a narrowing of the valve. The other possibility is a valvular regurgitation. In this case here, the valve isn't narrowed. It opens up like it's supposed to. Blood is able to pump through the valve. Okay, so no big deal there, but it doesn't shut all the way. And because it doesn't shut all the way, what's going to happen then is fluid moves backward. So we're going to get the backward flow of fluid as a result. This is a picture here showing a valve that has become diseased. And you can see all of the junk on that valve. That valve should have a nice, rounded, smooth shape to the edges as they're coming together, and it does not. They're kind of all chewed up. And that's going to lead to dysfunction. There's going to be leakage of fluid through that valve where there normally should not be. There's some great videos here about valvular disorders, so make sure that you're using these links and getting out there and taking a look at these different valvular disorders. These are included on your PowerPoint, or you can cut and paste them from your screen, but probably easier just to get them right off of your PowerPoint that's available on your course shell. Mitral stenosis is a situation where the mitral valve, okay, now when we're ever talking about valvular disorders, first of all, in your mind, think, where is that valve? And then what is the situation that's wrong with it? So in this case here, where is the valve? Mitral valve is between the left atrium and left ventricle. All right, what is the problem with the valve? Stenosis. That means it's narrower than it's supposed to be. So if stenosis decreases forward flow, that means that flow is not going to get to the ventricle, and we're going to have a decrease in cardiac output. So this talks about some of the different situations that can lead to a patient developing mitral stenosis, such as rheumatic heart disease. Aortic stenosis. Okay, again, whenever you're talking about different valves, think about the valve and think about the problem. Okay, the aortic stenosis, the aortic valve, is the valve that's coming from the left ventricle to the aorta. It's stenotic, so it's narrowed. That means we're not going to be able to pump out as much blood from the ventricle moving forward into the aorta, and our cardiac output will decrease. Acute rheumatic fever. This is a diffuse inflammatory process that's occurring in our patient that can cause the patient to develop rheumatic heart disease, and then the big problem with that is the patient's going to develop, or at least possibly develop, valvular dysfunction. Infective endocarditis, now we have a situation here where we have a bacteria that has gotten into the patient's body. It's infecting that inside lining of the heart. And again, one of the main things we have to be concerned with here is the possibility that that's going to start to damage the valves. Sure, it could damage the inside of the heart, and that causes problems too, because we're going to start to roughen up the lining inside the myocardium, and that can cause platelets to stick there, it can cause things to stick there, and it can cause emboli to start to form. So there's all sorts of problems that can result as a result of endocarditis, but one of the main things we're concerned about is that damage to the valves and having long-term valvular dysfunction. Some of the manifestations we see of heart disease include the thing called dysrhythmias. Dysrhythmia is an abnormal heart rhythm. So dysrhythmia is an abnormal heart rhythm. The patient may have missed beats, they may have additional beats, they may have a rate that's too fast or too slow. These are all abnormal rhythms to the heart. We should have a nice steady beating of the heart that is consistent. That would be a normal rhythm. And when we have anything that's not normal, we call it a dysrhythmia. Another term you may hear is arrhythmia. These terms in clinical practice are used interchangeably. Really, arrhythmia means that there's no rhythm. So dysrhythmia means there is an abnormal rhythm. So really, I guess, at least grammatically, the better term would be dysrhythmia. But you may hear both of them used in clinical practice. Now, what we're seeing here at the bottom of the page is an EKG that came from a patient. Even if you don't know what that means, you don't know how to read it, one thing you could say is, wow, it looks like that thing is pretty fast. So that would be a dysrhythmia because the rate is too fast. In fact, the rate in this patient is very fast. And the rhythm here that we're seeing is called a ventricular tachycardia. Ventricular tachycardia is an abnormal rhythm that can lead to cardiac arrest. This diagram here is showing some of the things that can happen when your patient has myocardial disease. So let's take a look at some of these different things and how they're affecting each other. Left ventricular dysfunction, starting at the bottom of the page, can cause electrical instability in our heart. So if the ventricle isn't functioning very well, it can cause electrical instability. The electrical instability itself then can cause more left ventricular dysfunction. The electrical instability can cause ischemia because we're not getting a normal rhythm in the heart. At the same time, the ischemia can cause left ventricular dysfunction, whereas left ventricular dysfunction can cause ischemia. You see how we can get into this vicious cycle where we're just moving around this thing here, and the patient's cardiac function just keeps getting worse and worse and worse. Yes, that can happen as a result of this process. So something to keep in mind here is that this can happen as a result of this process. Take a look at some of those components as it goes along the diagram. You might want to pause the video here for a few moments to look at the diagram and really take in everything that it's telling you. When a patient has decreased cardiac output, there are going to be compensatory mechanisms that kick in the body. And those compensatory mechanisms are the sympathetic nervous system, the renin-angiotensin system, we also called that before the renin-angiotensin-aldosterone system, and aldosterone itself. Okay, so those three things are our three major compensatory mechanisms that kick in when the patient has a decreased cardiac output. These compensatory mechanisms have no idea. The body has no clue as to what's causing the decrease in cardiac output. The decrease in cardiac output could be caused by any number of things. It could be caused by dehydration, could be caused by a cardiac problem, which is what we're talking about now, could be caused by sepsis. We don't know. The body doesn't know and the body doesn't care. The body will respond in the same way every single time, and it stimulates these compensatory mechanisms. All right, let's take a look at this in terms of a patient who is dehydrated. With a patient who's dehydrated, this stuff makes sense. So you're going to walk across the desert, not bring a canteen with you. Your body's going to try to maintain cardiac output for as long as possible. It does that by stimulating the sympathetic nervous system, and the sympathetic nervous system is going to increase your heart rate and your cardiac output, maintain your cardiac output for as long as possible. Next, the renin-angiotensin system kicks in, and it's going to increase your blood pressure to, again, maintain cardiac output. Lastly, aldosterone kicks in, and aldosterone is going to tell the kidneys to hang on to more fluid, again, to maintain cardiac output. These things work when you're dehydrated. What about in a situation, though, where a patient has a cardiac problem? In a cardiac problem, and the patient's, let's say, having a heart attack, they have decreased cardiac output because the heart isn't functioning very well. Sympathetic nervous system kicks in and tells the heart to beat harder and faster. Don't you think it would have if it could have? Okay, that's not going to help. The renin-angiotensin system kicks in and it causes vasoconstriction. It kinks the tubing. Well, that's not going to help. Think about your garden hose. We're going to decrease our cardiac output. We're kinking the tubing. The aldosterone system kicks in. It tells the kidneys to hang on to more fluid. We don't need more fluid. We can't even pump the fluid we have. So these compensatory mechanisms are all going to be dysfunctional in a patient who has a cardiac problem. So what do we do about them? We're going to treat the sympathetic nervous system by giving the patient beta blockers. That's a type of medication that's going to block the sympathetic nervous system. We're going to treat the renin-angiotensin system by giving the patient ACE inhibitors. Some people can't tolerate those, so instead we'll use ARBs, angiotensin receptor blockers. We're going to block the aldosterone system by using aldosterone antagonists. Okay, don't worry so much about the medications at this point in time, but just understand that we have mechanisms we can use. We have medications we can use to block these compensatory mechanisms. And the reason why we want to do that in our cardiac patient is because their compensation makes them worse. Left heart failure, and heart failure in general, is the result of our compensatory mechanisms making the cardiac function worse in that particular patient. So we get symptoms of pulmonary vascular congestion, inadequate perfusion of our systemic circulation as fluid is backing up from the left side into the lungs and not getting out there into the tissue. Now we can break up heart failure into two different types. We can call it systolic or diastolic. What this picture here is illustrating what happens with our cardiac output in patients who have systolic and diastolic dysfunction. Now these diagrams are illustrating the ejection fraction of the heart. The ejection fraction is the amount of blood that is pumped out of the heart with each contraction. So with a normal contraction of the heart, we pump out about 65 to 70% of the blood that's in the heart. Not every drop, but we pump out about 65 to 70%. With a patient who has systolic dysfunction, systolic is contraction. So the patient has an inadequate contraction of the heart. Well, they're going to have a low amount of blood volume pumped out of the heart. In fact, now this patient's only pumping out 35% of the blood they have in the heart. That's systolic dysfunction. And obviously, if we're only pumping 35% forward, that means that we are not getting a lot of cardiac output, and blood is going to start to back up. On the other hand, diastolic dysfunction is the result of inadequate relaxation of the heart. So the heart's not fully relaxing, so it can't fully fill. Now the heart still has a strong contraction. So we're able to pump out 65% of what's there. But the way the patient develops heart failure in this case is because we started with less. Look at the volumes in those three compartments. We started with less. So even though we're pumping 65%, we started with less to begin with. And we still end up having a decreased cardiac output. Right-sided heart failure most commonly is going to be the result of left-sided heart failure. So it's just commonly caused by hypoxic pulmonary disease. Yeah, if we have isolated right-sided failure, it would be commonly from hypoxic pulmonary disease. Could also be from pulmonary hypertension, but most right-sided heart failure is the result of left-sided failure. The left side fails, backs up through the lungs, and backs up into the right side, and then the right side fails too. Shock is a situation where we have decreased perfusion of the tissues. So in shock, we have decreased perfusion of the tissues. Now, there's a lot of things that we use to help us to be able to determine shock. In other words, oftentimes we will look at things like our vital signs, etc., to tell us that the patient has shock, but shock state itself is a state of decreased perfusion to the tissues, and that is not dependent upon the blood pressure or the heart rate so much as it is what that particular patient needs. Shock can be divided up into different types, including hypovolemic, cardiogenic, neurogenic, anaphylactic, and or septic, depending upon what it is that's causing the patient to have shock. So these are all different etiologies for shock. But shock itself is going to be the same process, irregardless of what it is that starts it. In that shock, again, is decreased tissue perfusion. It's decreased perfusion of the tissues, and that's going to be the same process whether it's hypovolemic, cardiogenic, etc. Untreated, it's going to overwhelm the compensatory mechanisms, and the patient's going to have cell death. and can progress to multi-organ dysfunction syndrome, in which case now we're going to get secondary damage to organs that are even distant to the original problem. So let's say the patient has cardiogenic shock, which comes from having a heart attack or having decreased cardiac function. So the patient's got decreased cardiac function that's causing the patient to have shock. So the heart's not pumping well, cardiac output goes down, the patient develops shock, and it's caused by cardiogenic, it's caused by the heart. If that does not get treated, then the decreased cardiac output over a long period of time will cause other organs to fail, like the brain, like the kidneys, because they're not being perfused. This is the thing that happens that's called multi-organ dysfunction syndrome. All right, now this is kind of a busy little slide here, so let's take a look at it and dissect it a little bit. But what it's showing is what happens with impaired cellular metabolism that's caused by decreased tissue perfusion. So a lot of stuff going on here. You don't need to know all this detail when we're dealing with talking about our cardiovascular system. But this is a slide just to look at for a while and try to follow through and see what parts of this you've got already and what parts of this still are kind of a little bit troubling to you. So as we look over, let's go over to the right-hand side here where it says impaired glucose use. Now remember, you learned about earlier in the course, you learned about decreased glucose use in a patient who has anaerobic metabolism, and that leads to an increase in pyruvate, which then leads to the patient developing an increase in lactate and metabolic acidosis. So you can kind of see how some of those things are starting to fit in here a little bit. Over on the left-hand side, impaired oxygen use leads to anaerobic metabolism, again, there's your lactate, and decreased ATP production, dysfunction of the sodium-potassium pump, increases in intracellular sodium and water. Remember, if the pump isn't working, we can't keep that sodium out, and sodium starts rushing in, water follows it. Now we have cellular edema, which then can cause destruction of the cell. So follow this thing through some of these different pathways here and see if you can explain it based on some of the things that you've already learned as to why these processes are occurring in a patient who has decreased tissue perfusion. Hypovolemic shock is a type of shock that's caused by a lack of volume. So the problem here is a lack of volume. We've lost volume somewhere. The problem with hypovolemic shock is you can't put it back. Okay, so if the patient was bleeding, you can't just grab up all the blood and put it back in. Okay, so whatever the patient loses, we're going to have a hard time replacing it. Now, you're going to hear in the clinical area, you're going to hear people talk about giving replacement fluids. Okay, replacement fluids don't replace what was lost. I can give this patient blood from the blood bank, but that's not his blood. See, that's going to be a little bit different, and it could cause some kind of reaction in the patient's body. What if he's got burns and he loses a lot of fluid from burns? I'm not replacing the fluid that's been lost when I give IV fluids. I'm giving that patient a cheap substitute. So whatever we're going to do to, quote, replace fluids is going to be a cheap substitute. Therefore, the number one thing we want to do in hypovolemic shock is to stop the loss. Plug the hole. Let's stop this loss from continuing. But the problem that occurs here is that the patient has decreased volume. So there's not enough volume to pump, and then the patient ends up developing hypovolemic shock. So let's follow this diagram down. At the top, we have decreased intravascular volume causing decreased cardiac output. Again, the heart is just a pump. It's going to pump what it gets, and if it doesn't get anything to pump, it doesn't have anything to pump, and the cardiac output goes down. Okay, pretty simple that if there's no volume coming in, there can be no volume coming out. On the right-hand side of the screen, we have decreased cardiac output, which is going to cause our catecholamine release. Remember, we have those compensatory mechanisms, the first of which is sympathetic nervous system. There's our sympathetic nervous system. It's going to cause an increase in heart rate and contractility, which will temporarily increase our cardiac output. On the other side, we have our shifts in our interstitial fluid. We have our aldosterone secretion. So those things are going to help to hold on to volume. So increase in heart rate, increase in volume, our cardiac output is at least temporarily increased. More volume loss, okay, now we're overcoming what those compensatory mechanisms can do, and our cardiac output further decreases, and our tissue perfusion decreases, and then we get impaired cellular metabolism at the tissue level. Cardiogenic shock is caused by pump failure. In other words, the heart has failed, so cardiogenic, cardiac, is referring to the heart. Most commonly, this is going to be the result of the patient having a myocardial infarction. Myocardial infarction causes cardiogenic shock more frequently than other things because it's sudden. And we have now an area of the heart that's no longer functioning. And the heart doesn't get a chance to accommodate for that. Some of the other things that can occur here, like valvular dysfunction and heart failure, the patient may be able to accommodate for that and not develop shock as a result. Okay, let's take a look at this picture. Our cardiac output has decreased because the patient has myocardial infarction, heart failure, etc. That causes those compensatory mechanisms to kick in to try to maintain our preload, our stroke volume. Okay, remember preload is the volume of fluid coming to the heart. Okay, well, we already have a lot of volume coming to the heart. We don't need more, but the body's telling it to hang on to more. That's going to increase our myocardial oxygen requirements. Cardiac output and ejection fraction are going to temporarily at least increase when we have these compensatory mechanisms, but eventually they're going to decrease as a result of further ischemia and further decreases in tissue perfusion. Neurogenic shock is caused by massive vasodilation. So we have unbalanced parasympathetic activity. Remember, sympathetic activity causes the fight or flight. It causes the increase in our heart rate, increase in our blood pressure. Okay, so the sympathetic system is causing vasoconstriction, maintaining the pressure in the vessels. Parasympathetic is just the opposite. Parasympathetic is causing vasodilation, relaxation of those vessels. If those vessels relax, we won't have enough pressure in there to maintain blood pressure, and that's what causes neurogenic shock. Neurogenic shock is going to be caused by having either some kind of a lesion in the spinal cord that's going to interrupt our sympathetic nervous system innervation, or a central nervous system problem, a problem that's occurring in the brain. So we have a decrease in our sympathetic stimulation with an increase in our parasympathetic. Usually that's because the sympathetic stimulation has been cut off. So we've had an injury in that spinal cord, and we no longer have the sympathetic system innervating the body. So we get a decrease in vascular tone, vasodilation. Our systemic vascular resistance goes down, which causes then a decrease in cardiac output and a decrease in tissue perfusion. Anaphylactic shock is the result of having a widespread hypersensitivity, in other words, allergic reaction. As a result of this allergic reaction, the patient gets a massive vasodilation. So this is very similar in what happens physiologically in neurogenic shock. It's just the cause is different. In this case, the cause is the inflammatory response. Remember, inflammation causes vasodilation. So here we have a massive inflammation that's occurring as a result of an allergy. And that massive vasodilation then causes the patient to drop their blood pressure and decrease their tissue perfusion. So here we have the allergen. The allergen, and this top part here is just showing you the process of developing an allergic reaction. So we develop an antibody, IgE, and the complement, histamine, etc., is going to stimulate the inflammatory response, which increases capillary permeability and causes vasodilation. Those things are going to lead to a relative hypovolemia. So this relative hypovolemia, the fluid's out there. It's just out there in the tissues and out there in the peripheral system. So what we need to do in order to fix this is we're going to have to get that fluid back into the central circulation by giving the patient something to vasoconstrict them. But in the meantime, we have decreased cardiac output, which is causing impaired cellular metabolism. So here's some causes of anaphylaxis. The treatments listed over on the left-hand side, they're epinephrine and Benadryl. Those things are directly affecting the allergic reaction. Steroids are going to decrease inflammation. Okay. Pepsid is an H2 blocker. It's a histamine 2 blocker, which can block some of the histamine that is not blocked by the Benadryl. Septic shock. In septic shock, we have a situation where the patient develops an infection and that gets into the bloodstream. Now, this terminology can get a little bit confusing, so I'm sorry about this. We're going to get into a little bit more definitions here in just a moment. But when we talk about septic shock, most of the time what people are thinking of is they're thinking of an infectious process that's occurring in the patient's body. And because of infection, we get an overwhelming, out of control inflammatory response. And remember again, what happens with inflammation? We get vasodilation. So this diagram here is just showing how we get this inflammatory response started. We have the gram-negative, gram-positive organism that gets into the bloodstream, and then that is stimulating our inflammatory response. If you go down to about halfway down the page, it talks about SIRS, S-I-R-S. That's the Systemic Inflammatory Response Syndrome, where we have this overwhelming, out-of-control inflammation that's going on in the body, and that causes the next step, which is vasodilation, hypotension, and tissue inflammation, tissue hypoperfusion. Eventually, that leads to worsening of our hypoperfusion and multi-organ dysfunction. The pathophysiology of sepsis. We talk about sepsis being both of the presence of a systemic infection and our systemic inflammatory response syndrome, and then this causes the ultimate results we're going to see. We're going to kind of look at this in more detail here in just a moment. Some of the components of the systemic inflammatory response syndrome include white blood cells being released, pro-inflammatory cytokines, tumor necrosis factor, and interleukins. Okay, let's take a look at this diagram a minute and see how all these things plug in together. We have an initiating factor that's causing this thing, and notice that the terminology is different. The terminology says sepsis syndrome as opposed to septic shock. This idea of sepsis, we have found out, is that not only is it bacteria and an infection that causes this whole process to occur, but it can also be injury or ischemia. Because of that, they're now changing the terminology somewhat to be sepsis syndrome. So if you hear that a patient is septic, I think in most cases what you're going to find is the patient probably has an infection. However, sepsis syndrome could include the same results as septic shock from an infection. So let's take a look at what happened. We're going to follow infection across and then plug in one of these other ones. So the patient has an infection. The patient comes to the hospital because they have a urinary tract infection. Bacteria from that urinary tract infection get into the bloodstream, and they cause an overwhelming, out-of-control inflammatory response. That's this thing here in the middle, the inflammation part. And we also call that SIRS, Systemic Inflammatory Response Syndrome, SIRS. So that's this overwhelming inflammation that's happening in the middle. One of the main components of inflammation is we get vasodilation. That causes severe sepsis. In severe sepsis, we have massive vasodilation going on that's causing a drop in the patient's blood pressure. That drop in blood pressure will respond to giving the patient IV fluids. If the drop in blood pressure does not respond to IV fluids and continues to get worse, we call that septic shock. Lastly, if this process continues to go on for a long enough period of time, we'll start getting secondary organ dysfunction as a result of the other two components involved in inflammation, which are capillary permeability and clotting. Capillary permeability causes edema. Clotting causes little microclots inside the tissue, and those two things together are going to cause tissue damage. In the lung, they're going to cause ARDS. In the kidney, they're going to cause acute renal failure. In the hematologic system, we're going to use up our platelets, and the patient will develop a process called DIC, disseminated intravascular coagulopathy. Next, we can get liver congestion and liver failure, heart failure, and then anoxic brain injury. These results of multi-organ dysfunction are the direct result of the systemic inflammatory response that you see in the middle of the screen, which were initiated by that infection, injury, or ischemia. So multi-organ dysfunction syndrome, what happens here is that the patient is having damage to two or more organ systems as a result of this initiating factor and the systemic inflammatory response. Failure of two or more of the organ systems is going to cause a very high mortality rate in our patient. So even if the patient was a fairly healthy patient to begin with, once we have two or more systems starting to fail, the mortality rate increases dramatically. Multi-organ dysfunction syndrome is really just a name for the fact that we're getting distal injury to organ systems outside of the original organ that was damaged from the shock. So maybe it's a myocardial infarction that's causing the patient to have decreased perfusion and the systemic inflammatory response syndrome that is activated. And then other organ systems distal to that become involved. Primary multi-organ dysfunction syndrome occurs with the direct injury from whatever the underlying problem is. Then secondary, and this is what we usually refer to as being most of our MODs, is the consequences of our systemic inflammation. Signs of organ dysfunction include respiratory failure. Again, that would be an indication of ARDS. Acute renal failure, hematologic dysfunction. We'd see that evidenced by seeing a decrease in your patient's platelet count. Liver failure. Okay, we can see that evidenced by an elevation in our liver enzymes, cardiac dysfunction, and then finally, anoxic brain injury. We're going to see that evidenced on an EEG and maybe something like an MRI of the brain. Risk factors include age. The older the patient is, and we should also add to that the very young. The very old and the very young have less control over their immune system than do adult patients. Baseline organ function is a risk factor. If your patient already had some underlying renal dysfunction and then has multi-organ dysfunction on top of it, much higher chance that they're going to end up having dysfunction of the kidneys. Immunosuppression, malnutrition, inadequate or delayed resuscitation can also have an effect on how much multi-organ dysfunction occurs. Significant tissue injuries. The most common cause of all multi-organ dysfunction syndrome, MODS, is septic shock. So overall, some of the symptoms we're going to see as a result of shock are highlighted on this page here. Early signs in blood pressure could be normal. Early sign in our heart rate could be a little elevation. Skin color may still be normal. Skin may be a little cool and moist. The patient may be a little anxious, and the respiratory rate may be a little increased at this point in time in the early phase. Remember, our compensatory mechanisms are kicking in early shock. Later in shock, if it's allowed to persist and the patient's blood pressure starts to fall, we're going to see other symptoms. The blood pressure now is falling, the heart rate's up, and the heart rate is now becoming weak because we don't have enough blood pressure to maintain a nice solid bounding pulse. Normal, our skin color becomes pale and the skin becomes cool, maybe moist at this point or maybe even dry. The patient's going to start to lose consciousness and respirations start to become more shallow as the patient doesn't have enough energy getting to the respiratory system to continue to have good respiratory function. Well, I hope you have enjoyed our presentation of alterations in cardiovascular function, and that this helps you in forming your study and figuring out what parts of the cardiovascular system are most important to study when you're looking at your cardiovascular dysfunction. Thanks for joining me. Until next time, bye now.